Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and it's the first episode since Maddie is back from her maternity leave. So, congratulations, Maddie, and welcome back.
Thank you. Nice to be back.
It's such a long time, and it has been a significant break. And I think it's a good break for all of us from this podcasting journey. But I'm so happy and excited that Maddie is back now. So, really looking forward to having more episodes this year.
Yeah, me too. Hopefully we can help some more trainees out when they're studying for their exams.
Great. So let's dive into today's primary snippet. So we are going to continue with the theme of snippets, which we had last season, and we will try to cover the primary syllabus in small chunks. So today, the topic is the renal physiology. So can you please describe the physiological mechanism by which the kidney concentrates the urine?
Sure. So the kidneys are able to concentrate urine to a maximum of 1,200 to 1,400 milliosmoles per litre. And this aids in helping maintaining the intravascular volume. And the reason that the kidneys are able to do this is by two main mechanisms: by having a high osmolarity of the renal medullary interstitial fluid and because of the presence of antidiuretic hormone. So if we think about firstly the maintenance of a hyperosmolar renal medullary interstitium, this depends on the countercurrent mechanism, which occurs in the juxtamedullary nephrons, and this involves the loop of Henle, vasorector, and intrarenal urea cycling. So diving a bit deeper into the countercurrent mechanism, we know that the descending limb of the loop of Henle is highly permeable to water, but it's not permeable to solute. So as the fluid goes down the descending limb of the loop of Henle, it becomes more concentrated as the water exits the loop, and the osmolarity then equalizes to the outside renal medulla. So as it becomes more and more concentrated, you can imagine that at the bottom of the loop, it's maximally concentrated. Now, when we get back up to the thick portion of the ascending limb of the loop of Henle, the solutes are now actively transported out, and this is by the sodium-potassium 2 chloride cotransporter. And this establishes a concentration gradient between the interstitial fluid and the tubular lumen, and this is about 200 milliosmoles. This osmotic gradient is then also maintained by the thick ascending lumen being impermeable to water. So that means that solutes can exit, but the water can't. Some sodium chloride is also reabsorbed from the thin ascending limb, but water remains impermeable, which also adds to the high solute concentration of the interstitium. As the tubular fluid travels up the ascending limb, it becomes less concentrated due to solutes being pumped out without water, and it then leaves the ascending limb less concentrated than when it enters the descending limb. So this transport of ions out of the thick ascending limb results in a hyperosmotic interstitial fluid, and water then moves out of the descending limb into the interstitial fluid due to the concentration gradient. New tubular fluid enters the descending limb, which moves the higher osmolar fluid further down the descending limb, and thus forms an osmotic gradient as more solute is added to the medulla in excess of water. So this means that eventually the interstitial osmolarity reaches 1,200 to 1,400 milliosmoles a litre. This can be quite confusing to think about just listening to. I would highly recommend also looking at some of the graphics that are available online or YouTube, which just shows the process. So it's a continual process, which is kind of easier to understand in graphic form. So that's the part of the tubular mechanisms. And then we think about the vasorector. And these are specialized peritubular capillaries of the renal medulla that run parallel to these loops of Henle. And they help to maintain this high osmolarity of the interstitial fluid because, firstly, the blood flow is low. It has only less than 5% of total renal blood flow, and this helps to minimize any solute loss from the interstitium to the blood vessels. They also act as a countercurrent exchanger. So as blood becomes more concentrated as it descends into the medulla, as solute enters from the interstitium and water leaves, it has a concentration of about 1,200 milliosmole a litre at the tip of the vasorector, which, as we've just talked about, is the same as the medullary interstitium at its most concentrated. As blood then ascends towards the cortex, the solutes diffuse back into the interstitium and water enters and blood becomes more dilute. So this is similar, as we talked about, to also the renal tubule system. Consequently, there is little change in the concentration of the interstitial fluid, as the blood within the vasa recta is similar in concentration to the interstitium at each level of the medulla. This therefore maintains the high osmolarity of the interstitial fluid. Then the third part is intrarenal urea cycling. So urea contributes almost 50% of the renal medullary interstitial osmolarity. It's freely filtered in the glomerulus, but becomes more concentrated in the proximal tubule due to water reabsorption in excess of urea reabsorption. So the thick ascending loop of Henle, the distal and the cortical collecting ducts are all impermeable to urea. But in the presence of antidiuretic hormone, there's increased water reabsorption from the cortical collecting tubules, and the urea concentration increases rapidly as it is impermeable. More water reabsorption occurs in the inner medullary collecting ducts, further increasing the urea concentration within these tubules. And as the medullary collecting ducts are permeable to urea, it can diffuse out into the renal interstitium. One of these urea transporters, UTA1, is activated by ADH and thus increases the transport of urea into the interstitium. This increased urea diffuses into the thin descending and ascending limbs of the loop of Henle and eventually back to the collecting tubule, recirculated many times before it is excreted. This helps maintain the high urea concentration within the interstitium. So I know that sometimes we've given people urea tablets. I don't know if you've ever done that for patients in ICU. Have you ever done that, Swapnil?
I guess that's commonly used for the treatment of hyponatremia, IDH management. But again, there's no evidence for using urea tablets.
Yeah. So I guess the theory behind it is that sometimes patients with hyponatremia, they wash out their urea and therefore affect this concentration gradient. And if they don't have that concentration gradient, they can't maximally concentrate their urine. So they might actually become hyponatremic. And then the third part, which is related, as we've said, to the urea, is antidiuretic hormone. And this is required for maximal concentration of urine to be achieved. And we know that antidiuretic hormone is activated mainly by increased osmolarity and decreased circulating volume in the body. So ADH results in the luminal expression of aquaporin channels in the late distal tubule and collecting ducts. And water is thus passively reabsorbed into the interstitium, driven by the osmotic gradient established by sodium chloride and urea, as we've outlined before, through the countercurrent mechanisms. And therefore, urine can be concentrated. So we see clinically in patients, say, with severe traumatic brain injuries and brain death, that they can actually become very polyuric because they're not producing antidiuretic hormone, and they can become very hypernatremic. So without antidiuretic hormone, you aren't able to concentrate your urine effectively and can thus just lose a lot of free water.
Thanks, Mary. So that's a very comprehensive answer. Thanks for bringing some of the clinical applications into your answer, because as a primary candidate, it's important to understand why we use certain medications into certain conditions, like urea tablets, for example. Obviously, this is a very comprehensive answer. And when you try to write this answer in 10 minutes time, you might struggle to put down everything in written format at sentence to sentence or word to word. So one of the tip is to use a lot of diagrams, and at each stage, whether it's a countercurrent multiplier or exchanger or even the urea transporters or the role of ADH, there are good diagrams available in most of the standard physiological textbooks. So maybe using that diagrams will help you to cut down the written content.
Yeah, this would be impossible. I put a lot more detail than correct me if I'm wrong, but that you'd be expected to within 10 minutes.
The details are expected, but at the same time, you need to work out the balance between using the diagrams and the content. And I think in that case, you can still able to convey the same level of understanding in one answer. But this much of knowledge is definitely expected from the primary candidate. So thanks, Mani. So that's the end of our today's episode. We'll be back in week's time with another snippet. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.